2017 has been a big year for bladder cancer with multiple FDA approvals of checkpoint inhibitor for the treatment of bladder cancer. So I think it's really exciting. I think a lot of the exciting things that we're seeing also now is how these agents are being moved to earlier states of disease, like such as non-muscle invasive bladder cancer and muscle invasive bladder cancer, and combination therapies. We know what the efficacy is for monotherapy, so we're trying to do better, and I think it's important to look out for toxicity in these combination therapies, but I think that's really exciting if you take two agents that are active and put them together and see what effect that you get, what efficacy you see in patients with advanced bladder cancer or even patients with non-advanced bladder cancer in earlier states of disease.
So in 2017 in renal cell carcinoma, I think the major breakthrough was the report of the Checkmate 214 study at ESMO this year. This study randomized patients to the combination of nivolumab and ipilimumab for 4 doses, followed by nivolumab maintenance, versus the standard of care was sunitinib. And it showed that in metastatic patients with intermediate and poor risk, the combination immunotherapy really improved overall survival. The median overall survival was not reached at the time of the report at ESMO. In addition, it numerically extended progression-free survival by about 3 months, but it did not reach statistical significance because the alpha was split between both progression-free survival and overall survival. So we look forward to hearing further results as the overall survival endpoint matures, but I think that the landscape certainly is changing for first-line treatment of metastatic renal cell carcinoma based on this data.
I think the biggest advancement that we're seeing in CLL is the many different trials that are now getting patients to MRD negativity. I mean, this is a tremendous advancement in the field. If we think about perhaps when I began my career, we were talking about complete remission rates in the single digits. Now we're having overall response rates of 100%, complete remission rates of 3/4 of patients, and MRD negativity in all patients or the vast majority of patients. So that's an incredible new endpoint for trials and for patients, and an important step towards fixed duration therapies, but we're getting people off therapy rather than having to treat them continuously.
The biggest advancement, I would say, is the recognition that BCMA is a very good target in myeloma. We had CAR-T data, we had ADC data that were presented. We also had preclinical data being presented with the bispecific T-cell engager technology. So there are different ways in which we're trying to target BCMA. I think the other important aspect was the MRD methodology and consensus. People are starting to do next generation flow and NGS in a similar way for the most part, whereas there used to be many different methodologies in the past. There's also good recognition that methodology, that MRD negativity actually leads to better survival outcomes. So I think those are the two main themes that I would say are probably the highlights.
I think the biggest advance in melanoma in 2017 were the 2 adjuvant trials, without question. 2017 will be ended in less than 6 weeks, and I think those will have the greatest impact. It will hugely increase the number of patients that get treated and benefit from either targeted or immunotherapies. And if we see that increased tail on the curve of survival and relapse-free survival, we'll be in good shape.
The biggest melanoma advancement in 2017 was clearly improvements in adjuvant therapy for high-risk resected melanoma. No question we saw dramatic benefits of both BRAF and MEK inhibition in patients with resected stage 3 melanoma, and also benefits of the PD-1 agent nivolumab in resected 3B, 3C, and 4 melanoma. So I think now we're treating patients that have had surgery to remove their cancer who may be at risk of relapse. hopefully these drugs, as they've shown to be done already, will decrease the patients with metastatic disease, and hopefully with less patients with metastatic disease, that will translate to longer cure rates really in the long term. And I think that was the biggest advancement of 2017.
Obviously, the adoption of immunotherapy and really I think the widespread implementation of immunotherapy as frontline treatment for metastatic disease, that's really been the main thing. And I think for surgical patients, I know that we're still conducting the Alchemist trial, but the randomized trial in China that looked at gefitinib as adjuvant therapy for patients with EGFR mutant lung cancer. Really, that was the first positive trial of a biomarker-driven targeted therapy in earlier stage patients and surgical patients. And I think having a trial that was positive is really exciting and gives us some optimism for the other arms of the Alchemist trial.
The biggest advancements in 2017, I think, would be looking at more effective first-line agents, as we see with alectinib for ALK and with osimertinib for EGFR, and starting to learn how to better sequence them, but also providing more efficacy with less toxicity for patients. And then BRAF mutations, though a small cohort, we now have an FDA-approved combination for these patients. And then the advance of immunotherapy even further. Now we have first-line setting, and immunotherapy clearly changes the biology of the disease, as we see patients have better survival, despite the fact that even patients who potentially got chemotherapy in the first line would get second-line immunotherapy, still had lesser survival than those who got it in the first line. So there's a clear change in the biology. So the frontier in front of us has a clear vision to help to try and understand that, because if we can change that biology for more people, we may help more people live longer.
I'm completely biased because my entire career has been spent looking at genetic susceptibility, but the idea that we can use why a person developed cancer, this increased risk, this genetically informed increased risk of cancer, and then we can use that as the Achilles heel and target it, and that it is better than chemotherapy, taking a pill and not losing your hair, is actually pretty remarkable.
Well, I would say that one of the most important advances has been the initial demonstration of PARP inhibitors, as we talked about with talazoparib. The first PARP inhibitor that was reported at ASCO just 6 months ago was olaparib, that is now showing a clear benefit. Another important advance that is really a follow-up from a trial that was done earlier is for early stage patients, where we're asking the question, what is the best way to use hormonal therapy? We know that blocking the effect of estrogen on tumor cells has a big impact on the number of people that recur, and therefore has a big impact on the cure rate. We are curing more early stage cancers with hormonal therapy, the initial one being tamoxifen, more recently aromatase inhibitors. And then for premenopausal patients, there was a big question as to whether we should suppress the ovaries, because it does cause more side effects of menopause. And that trial was completed and reported a few years ago, and the trial was negative. It didn't show a benefit, but it did show a benefit in a subgroup of patients that had higher risk breast cancer. And we thought that maybe with longer follow-up it might show a benefit in everyone, but even with that data, the guidelines were changed to recommend ovarian suppression in addition to hormonal therapy in premenopausal patients with higher risk, patients that had to get chemotherapy or that had positive lymph nodes. But now what we're seeing, just reported here at San Antonio, is with longer follow-up, the entire population that was studied is now demonstrating an improvement in disease-free survival and even overall survival. So that actually, because it affects so many people, I think that's a big advance.